and welcome to Head to Total, the podcast that pulls back the curtain on all things medical from the admin side all the way to today's guest, physical therapy. My name is Colleen Young, and today I have a very special guest. Her name is Katie Pring. She is the Director of Physical Therapy with Synergy Health Partners. Welcome, Katie. Can you tell us about yourself?
Yes, thank you, Colleen, for having me with you today. Like you said before, I am a physical therapist. I'm currently the director of the PT and occupational therapy services for Synergy Health Partners. I've been a therapist for 22 years, and out of those 22 years, I've been working for Synergy Health Partners for 15.
Let me just start us off by saying we've been talking to a lot of orthopedic surgeons, orthopedic physicians, and that's really why I wanted to have you on here, because I wanted you to talk to us about what exactly is physical therapy with respect to orthopedics, and how'd you get involved in that?
For physical therapy and orthopedics, we do a lot of different things. We're really treating any joint from head to toe, and we treat it many different ways. We're treating it by doing manual therapy, by doing exercises, by incorporating more functions with our patients that we're working with. I got into orthopedics because I went to Oakland University, and they have a really strong orthopedic program, and I fell in love with the orthopedics program there. And when I started working for Synergy Health Partners, it was just the best place to really horn in on my orthopedic manual skills.
Are you, correct me if I'm wrong, just so the audience knows a little bit more about your background, you sit on one of the boards at Oakland University or advisory committee for physical therapy?
I'm on their School of Health Science board at Oakland University, yes.
So what brought you to Synergy Health Partners?
I had worked 8 years in inpatient rehab, and I enjoyed it. But after 8 years, I was ready for something different, and I really enjoyed all my orthopedic training at Oakland University, and I really wanted to get back into that manual component, using my hands for treatment. And so I just had a change. I decided to go for it, and I saw that, at that time it was Mendelsohn Kornblum. Now it's known as Synergy Health Partners, and I saw they had a position open. And I went there not knowing much about the organization, not knowing much about, whether or not I was going to fit in. But one of the things on my very first day, they were very welcoming, but they also gave me the opportunity to improve on my clinical skills. So they said, hey, we want you to be part of our team, but we also want to invest in you. So we're going to establish some type of continuing education allowance with you, so you can take any class you want. And that way you can better treat your patients and just, invest in yourself. And I really like that, because for 8 years of my career, I did all my continuing education on my own. And so to know that my employer really took that as being an important part of me being one of their providers, I knew then that our patients were going to get the best care. And, I was just going to keep getting better as a clinician.
You mentioned, and can you explain to me and the audience, what is the difference between inpatient care and outpatient care?
So inpatient's the hospital. So if you're going to the hospital and you might get weak, you might have, other conditions. I did neuro, so I saw a lot of patients who had a stroke, sometimes a motor vehicle accident, which led to a head injury. So I treated a lot of neuro. And so in that setting, it's all about getting the person back to their home environment, back to function. So I did a lot of walking, standing, balance reintegration with my patients to get them safe so they can go home. Outpatient, they're home. And so my goal with them is to really improve on their current function and to make them, as much as I can, pain-free. And so the goals are really different. Whereas in inpatient rehab, I was just getting them so they could be maybe reach to table height, so they can be functional within their home. Where an outpatient, I'm getting them to reach even higher, up to the ceiling, being able to put things in the upper cabinet. So I'm taking that foundation and making it more advanced in their treatment.
When you're going through your continuing education, which is awesome because then you know you're getting the best therapy, right? Are you centered on one particular discipline? Because I've heard a lot about SHP's pelvic pain and pelvic floor program through physical therapy. Is that one of the things you could talk to us about?
Pelvic floor therapy is something that you don't get educated on at the university level. You get a course, and when I say course, it's one day a guest lecturer comes in. Maybe it's a few more days now, but you really don't get to learn how to treat your pelvic patients at the university level. It's an introduction, and if you're interested, then you have to pursue continuing education in that. And so I myself am a pelvic health therapist, and so when I started with Synergy Health Partners, we did not have a pelvic health program. We were all orthopedics. And I saw that there was a gap because a lot of my patients would come to me and say, oh, I have this pain. Once, it's real, it's real deep. It's just below my back, my spine. And they really couldn't tell me what the pain was. And they really didn't know who to go to. And so I decided one day to ask Synergy if I could start a public health program and could I start taking some classes on it. And they looked at me at first, it's like, okay, we're an orthopedic practice. How does this fit our patient profile? Are we going to be able to use these services? And I'm like, absolutely. And they said, okay, let's go for it. And they helped me tremendously by supporting me and giving me the resources to start a brand new pelvic floor program from scratch. And that's about 10 years ago.
When it comes to pelvic health, it's such a complicated, I think most people think of women when it comes to pelvic health, but it's also males. Correct me if I'm wrong.
Correct. And that's a big thing too, because when and it's interesting that you said that, because when I did first start the pelvic health program, I did start it with it being a focus on women. And so it was considered a women's health program. And then as I got dived into it, and I don't know how many courses I've taken since then, like 20, I realized that we were leaving out a big portion of our population. So myself and another one of my providers, we both treat patients who have female and male genitalia. And it's a service that we're just so blessed to be able to offer to our patient population, because pelvic dysfunctions or even pelvic pain is something that a lot of individuals deal with alone. And they're not really sure who to reach out to. So to be able to connect with patients, having them feel comfortable coming to you and telling you their issues is probably one of the biggest gifts I can receive as a provider.
It's difficult when, speaking from a woman's perspective, pelvic health, pelvic floor, and all is something hurts. Do you see a lot of endometriosis? Do you see, I think you're involved, correct me if I'm wrong, with a lot of athletes. I know you have recently opened an urgent care and physical therapy within a sports complex. What's it like a young athlete? What do they experience when they have pelvic pain, pelvic floor pain? What's that like?
Like you said, we opened our new Sportsplex out. Greg Grant's Sportsplex is what it's called. And we are treating some patients, young female athletes, for some pelvic dysfunctions. And that looks very different. We can be looking at stress incontinence. And you might say, oh my gosh, how can a young female athlete possibly have stress incontinence? It's considered an older person's disease, and that's not the case. And so we could treat individually volleyball players, basketball players for stress incontinence, and then you have your pelvic pain as well. And so you have individuals who come to us because they're having pelvic pain. And maybe about 10, maybe 15 years ago, that was considered normal and we didn't talk about it. But now, younger generation, they're so involved and they're able to look things up, and they want to take control of their health. And so they're more engaging at a younger age. And they're like, you know what? I don't need to be having X, Y, and Z, which is pelvic pain. I want someone to help me with it. So we can help individuals with pelvic pain as well. And you'll be amazed. Most of our pelvic pain and our urinary stress incontinence is because the athlete is weak. And maybe they're not weak in their pelvic floor. They're maybe weak in their core or their hips. And you're thinking, okay, why can weakness cause them to have pelvic pain? Well, a pelvic floor is just a small little bowl, and it houses all of our organs, and it has lots of muscles. And they want to work as hard as they can to keep us from linking. And then if you have the hip muscles, which are really large, or the core muscles, which are also a little bit larger, and they get a little lazy, then what happens is that pelvic floor muscle starts to overwork. And over time, it starts to fatigue and it starts giving pain. I like to use the analogy with my patients that it's like if you were to like crush your hand together and squeeze it together, and you're going to notice it. And at first you can tolerate it. But if you kept your fist crunched up, your hand crunched up like this for a considerable amount of time, you're going to start having pain, and you're going to start noticing it, and you're going to start, moving differently and everything. And that's what happens with our pelvic floor when there's the muscles around it are weak. The pelvic floor starts to go into a contraction mode to stabilize it. Our body wants to be stabilized, and it will do whatever it can. And then it starts to contract, and then it doesn't know how to relax. And we need to be able to contract and relax, not only to give us some relief from pain, but also to void so that we can, urinate. Because we need to be able to relax those pelvic floor muscles to allow us to have our bowel and bladder functions.
I don't think a lot of people realize all of that is happening in your pelvic area as you're moving around. I think when you're talking about ladies who play volleyball or ladies who are gymnasts, you always think of them as with such a solid core, and that they're operating at such intensity and their body is performing at such a high level. But I can completely understand, based on what you said, if all those other muscles are working, those pelvic muscles are also going to be contracted. And then, there is no release. So I could see why that would happen.
Yeah. And you have a really good point too, Colleen, when you're saying, okay, so you have these gymnasts and you have these young athletes, and they're very fit and they're very athletic looking. There's a difference between having muscle tone and being functional and being strong in a functional matter. And when we're talking about the core is not just the six pack, that we see. The core is like a cylinder, and it has to stabilize the pelvis from moving, as well as the lumbar spine. And all these muscles have to work together. And so if one muscle, like let's say when we look at the rectus, the muscles in front of the abdominal, the six pack, so to say, those might be overutilized. And our smaller muscles, the transverse muscles, which are used for our stabilization of everything, they might be weak. So that's why it's real important for people to understand, yes, you can be very fit and you can be lifting all these weights and doing all this stuff, but we also have to look at these small, stabilizer and making sure that they're doing their jobs and that another muscle group is not overpowering it to cause this disruption in the chain.
Now, is it the same in males as it is in what you just described, that the core and those cylinder muscles along the side holding everything together, it's the same for a male? Is that why a male could have incontinence with respect to pelvic pain?
Males, they have a lot more anatomy going on. So we don't really see a lot of young males having urinary incontinence. Part of it is because their anatomy, their urethra is longer, and then they also have a prostate. So I tend to treat a lot of my male patients for urinary incontinence for when their prostate was removed after surgery. Now, pelvic pain from men is very much real, and it's a very underserved population. And I think because we're not talking about it. And it's something too, so when you're talking about the pelvis and pain, you're talking about genitalia, which is a very sensitive subject for many. And there's a lot of shaming. So if someone does have pelvic pain and it goes into the genitalia region, there can be like, maybe they feel like they've done something wrong. And so a lot of it is they hide it. And then not only that, like, how can you comfortably say, I have this pain going on? I mean, Colleen, I think you can relate to me as well. You can go to a party and you can say, hey, I have knee pain, or I have shoulder pain. And you will have, like, everyone there will tell you about their shoulder pain. They'll tell you what they did with it. They'll tell you who to see with it. It's to see for it and everything. You cannot go anywhere and say, I'm experiencing such and such pain related to the pelvis, especially when it comes to the genitalia. People just don't feel comfortable saying it. And if they do, I don't know if there's going to be a lot of people to say, yeah, I too suffer from this.
That's a great comparison. And you're exactly right. I mean, it's an uncomfortable conversation to have. But I can tell you, as we go forward in this podcast, you're a very easy person to talk to. I'm sure that you have coached your staff on how to handle this appropriately. It's just getting people to talk about it and see, hey, guys, this is happening to a lot of people. It's nothing you've done. It could be whatever. I'm assuming that as we age, this could be more of a common problem for women as well as men, right? But we kind of talked about the athlete. Now, as we age, Katie, what then happens in that pelvic area, the pelvic floor, that causes other issues that we would come see you for?
There's a little bit of everything, after having childbirth, a vaginal delivery, you can have a lot of different things go on where it's maybe tearing, maybe a prolapse occur, which is an organ descending into the vaginal vault. We also have a very key thing called estrogen. And as we age, especially when we go into perimenopause and menopause, we can have that the estrogen actually will decrease. And what happens is estrogen is it's really good for plumping up our muscles. It gives its plumpness. And so when it starts to decrease, then we have a little bit of muscle atrophy. And the pelvic region, because part of its sensation is they have all these nerve endings around it. And so when those muscles start to atrophy, those nerve endings become very, very exposed, and that can cause pain for a patient. So, but also, for our male patients, they don't have the estrogen issue, but they can have like pelvic floor weakness. That just happens as we get older. We atrophy with our muscles. But also if they're experiencing any type of cancer, and if they're having any type of cancer treatment, so radiation to the area or chemo can be causing some muscle weakness and even some pain in a lot of cases.
It's just amazing to me how physical therapy is great for before a procedure and then amazing for after a procedure. Like I said, we were talking to Dr. Peter Lassiter the other day, and he was saying about the ACL and the MCL and how, even before the procedure that he does, he recommends physical therapy. And then after the procedure, he recommends physical therapy. And I don't think when people think that physical therapy, I think they do think of, every type of, well, I've had a surgery, now I got to go for rehab. But pelvic pain is something that you could be proactive with and come see people like yourself, people like your team, and really go down a great path of helping other issues that you may be having, right? I love how when you're talking to us about the younger athletes and who would ever think that a young volleyball player could be having incontinence issues. But I love where we're going with the older patients, probably because I'm an older patient, and I'm starting to hit that maybe my estrogen isn't as high as what it used to be. But that really is a great transition. Talk to me about and this could be a whole other podcast, Katie, but as we age, in addition to the pelvic floor and the pelvic muscles getting weaker, I've noticed myself, I'm a little off balance. I don't know if it's the inner ear. What happens, when it comes to is it? I think the word is vestibular.
Yeah, vestibular. So there's so many, different things that happen. As we get older, things just start changing. I joke with one of my therapists all the time that we wake up and every day there's a new, thing going on with us. Like it's a new adventure every day. But you were talking about the vestibular, and vestibular, when we look at it and we look at the inner ear, our inner ear has canals in it, and those canals have this gel within it. And what it does, it also has rocks. And as we're moving in space, those rocks move, and it tells us, oh yeah, you're good. This is how don't fall over. But as we get older, sometimes that gel can get a little sticky, and sometimes those rocks don't like it to move. And so then what happens is, you can have these periods of getting really, really dizzy, and all of a sudden you're losing balance, and you're falling, and you're like, oh my gosh, what's going on? And you go to the, and you start going, to this doctor and that doctor, and finally you wind up at ENT. And they're like, it's with your ear. And you're like, oh my gosh. And there is treatment that we can do with that from a vestibular standpoint, looking at the inner ear. There's some maneuvers that a therapist can put you through and have you do certain positions, and they take you, and all of a sudden they get the system starting to work again.
So it sounds like there's a lot more to talk about when it comes to balance. And I also understand that you guys also have somebody who is specialized or is working on their certification for vestibular problems. Once and I went through this with, I believe is a coworker of yours, Mitch Misiak, because he's running the orthopedic urgent care. And we talked about me falling. And when you say you're off balance and you take a spill, I got to go back to when you're treating the athletes, because concussions are a huge topic right now. Does the inner ear, is that why, the concussions, and how is all of that connected? What do you guys do in physical therapy when it comes to a concussion? And at that sportsplex where you have your new physical therapy location, what's happening there with concussions, and what's protocol and things like that for yourself physical therapy?
So that's a great question. So there's never one simple answer to anything. So when we're talking about concussions, it's any type of injury to the head. And it can affect a lot of different things, where it can affect concentration, it can lead to fatigue, anxiety, a whole bunch of stuff. So how we treat the individual depends on how the patient presents to us. And you're correct, Colleen, that sometimes it can be related to the inner ear because they sustain an injury and it hit, the side of their head. So one of the things that we're in the process of developing is a full concussion program where our urgent care is ready to do the assessment. They're going to do impact assessment training, which is done at the high school level. So any high school athletes, you have to do this anyways. And we're hoping to offer that for anyone in the future too, for, those requirements to play in a sport. But once an athlete gets hit in the head, or they get knocked out, or anything happens, sustains to their head, they're pulled out of that sport. Whether it's dance, cheerleading, basketball, football, they're pulled out, and they cannot return until they have what we call a concussion pre-assessment. So all athletes have to have that initial screen. And then once they get injured, we have to repeat that screen. And we need to say, okay, how did this change? And is this athlete safe to go back onto the field? Because the last thing we want to do is have an athlete go back out and be worse. And so that's one of the things that we're going to be able to work on as far as our urgent care. You get hurt, you get injured, we can do that assessment right then and there. Then we're going to talk about post-concussion. And that's when someone, for a couple of weeks, they had the concussion and they're still having some of the effects of it. Maybe there's some concentration issues. Maybe it's headaches. And we need to get them on the field. And we need to get them back. And so that's where PT comes in. Because now we can work on a whole bunch of stuff. Because if you think about a football player, there's a lot coming at you. And if you're suffering from headaches or concentration, you have to remember the color of your staff, your team's uniforms, maybe a player's number. People are coming towards you. And to someone who hasn't sustained an injury, that might be hard enough. That might be hard for like you and I. But then you have someone who has sustained a concussion and they're having some concentration issues. They might start to develop some depression because they can't do their sport. And we want our athletes to be able to do their sport, but also to do it in a safe manner. So we don't want them to stop playing their sport, but we want to get them back so they can be successful at it. And that's where therapy can come in. We can do a lot of scanning things and challenging all their discipline system, their vestibular system, their visual systems, having them stand on uneven platforms, just to get all the different systems working so they can go back on the field and be successful.
Katie, I think one of the things, we talk about head to total, right? We started with pelvic pain, but then we went to the ear and then we went to the concussion and all that. I want to go back to pelvic pain and kind of wrap that up because, those who suffer from various, again, female disorders, the endometriosis, polycystic ovarian, a multitude of other things, I think, PT is a natural fit, right? And I would encourage more people to try physical therapy and try to help instead of going on, they put you on some radical medications. And there's some things that some people don't want to put in their body. I think physical therapy is a wonderful option. But what you described to us too is there's so many other things in the pelvic floor and the pelvic area that we need to be conscious of. Is there a certain is it a sharp stabbing pain that people would feel if they've got pelvic pain? I mean, how do you I don't want to say self-diagnose, but how do I know, the pain is in my pelvis, not my lower back? Like, how do you distinguish? Is it sharp stabbing? Is it dull ache? Could it be both?
That's the challenges with pelvic pain, because pelvic pain can present as hip pain, right? It can present as back pain. And so anything that's below your belt and above your hips, I would consider, that's when you want to start paying attention. Anything that stops you from enjoying what you like doing. If you can't go to work, if you can't go to school, I mean, how many of our young females are staying home from school because they're having abdominal pain right before their menstrual cycle? We've got to start challenging those conversations. What can we do to help give these females some strategies to be in control of their pain? And I think that's where we got to start, is educating our teens that menstrual cramps, yes, they're going to happen, but when they start to impact your daily activities and you can't enjoy your sport, or you can't go to school, you can't go out with your friends, then we need to have that conversations with our providers. And our providers are open to it. We have to sometimes initiate this conversation. And that can be very hard. And I can say, even for one of my loved ones, we had to have that conversation with their provider. And the provider was awesome. Had I not maybe have known that I didn't want my loved one to be suffering from this pain, and that it wasn't normal, I don't know if I would have had that conversation, because when I was younger, I didn't have those conversations. It was normal. And so now my loved one is able to control it. And the doctor was able to give us some really easy solutions to help control it before it got out of control. And then this person also started some gentle exercising and stretching, which really helped as well.
I have to tell you, it's, they're not easy conversations to have. We do need to learn how to be more open. And in today's society, I know you're treating a wide range of people. It's great that you're so easy to talk to. It's great that you're encouraging your staff to go through additional training for pelvic pain, pelvic floor, and what can be done to help. If you would be open to it, Katie, I'd love to have you back because I think talking about vestibular imbalance, that's a whole other podcast.
Definitely.
As are concussions.
Yep.
Yeah. So would you be open to coming back, visiting us again, and taking some time and educating us on those two topics?
I would love to.
Awesome. Thank you so much.
Thank
Katie
you.
Pring, great to have you here. Thank you for the time today.
Thank you. Thank you for having me.